Hello everyone, good evening. We're going to start with the must know MCQs for this evening. We are going to discuss a lot of MCQ questions based on various topics. It's not just general anatomy, we are going to cover some of the questions from osteology, histology, gross anatomy, neuro, histo, many things we are going to cover. All right, let's see the questions before that. Just want to make sure that there is nobody who is having any queries about the classes that is being taken. So sometimes we have queries about what time the quiz is, what time the MCQs are, what time is the topic discussion. So all that we are going to check. Okay, we'll start with the first question. I'll just give you a brief introduction about myself. It is going to be very brief, and myself, Dr. Rohini, and I'm a NEET PG educator. So I'm an educator at NEET PG. Basically, I'm teaching anatomy this time. I would also be teaching the other topics from the microbiology and physiology in near future. So these two topics will also be taken in few months' time. And right now at present, I'm teaching anatomy. That is, I cover all aspects of anatomy, general anatomy, gross anatomy, histology questions. So my idea is to keep you very close to how the pattern of the NEET PG exam is. So I try to shuffle everything so that you get a idea to think in that direction. Otherwise, you will feel that it is very monotonous if you are thinking in one direction. So it is always important that you are able to quickly think. So since you have negative marking also, we have to be very careful with the options. We have to discuss if the options are A, B, C, D. We have to make sure that your answer is right. If you have picked the answer as A, then you should also know why your answer is not B, why your answer is not C or D. So that way you will get a good exposure to what is not the answer, why this is not the answer, so that why all your whys should be answered. So once your whys are answered, it's as good as you know the answers for 4 different questions, right? So your answers for B, C, D will also be discussed. That way, with one question, you have an answer of 4 questions. So out of one question, your gain is 4 questions. That's why discussing MCQs, discussing the topics, and then discussing the MCQ is important, because you will be able to interact well. So your interaction is very important to us. So I have my topic discussions. Each day we pick a topic and we have a topic discussion at 10:30 p.m. And this is the time when most of the people are done with their MCQs and other thing, and they're all ready for a new topic. So the end of the day, we have a new topic discussion, and you will get more time to concentrate on the new topic that we have discussed. So that time, 10:30. This is a special class. So this is a special class, and a special class is always interactive. And to have this special class, you need the app, that is Learners app. So please download the Learners app before this time so that you can interact with me, right? So Learners app is very important aspect. If you don't have the Learners app, then it is difficult for you to get into this loop, that is topic discussion loop at 10:30. And you can have a lot of queries. End of the day, you will have queries. You can join this group on Telegram. all your queries will be answered. You can also collect PDF notes. And even here you can collect the topic, whatever the topic is discussed, the notes can be collected in the PDF format. So that is one thing that you can download. And then Learners app is very important, very, very important. So you go to Play Store and look for the Unacademy Learners app, download it. You can check out the NEET PG educators, and under the section find me, Dr. Rohini, and then you can also follow and subscribe. You can follow, subscribe. By following and subscribing, you will get a notification. So you get a notification for all the classes that I not many classes you will find with the special classes. Most of the classes are MCQ based, but when do you read about the topics? So to read about the topics, to understand more about the topics, you need some discussion on the core concepts. So all the core concepts are discussed so that you are ready for your MCQ based questions. So MCQ based questions are held every day at 6 p.m. in the evening, and this is on YouTube, and again at 9:30 p.m. in the evening. It is also on YouTube. So this will give you sufficient time in between to check out the other videos that we have posted. You can follow and subscribe so that you can get access to all the educational videos that I have published so far. So kindly follow ROHAQUA. This is the name, username you can see, and please use the code ROHINI because this is just a glimpse or a a way to get into your subscription for the plus classes. So you will get an idea what exactly you can expect in plus classes. You have lots and lots more. You have lots of MCQs discussed, all clinical questions and scenario-based questions, everything, case studies, all this is discussed in plus classes, and you will be able to relate with the other classes. And you can set your own time. You can select what classes you want. Everything is under your control. So you also have some free classes. You have access to free classes. You have access to many things once you have your plus classes subscription. You can do that by availing some discount by using the code ROHINI from my side. All right, let's move on to exactly what topic today's we have. Okay, first question, we have a good number of students. Let's not make them wait. We'll start with the questions. The first one says, actions of latissimus dorsi. Latissimus dorsi. Now you have to think where exactly is the location of latissimus dorsi. It flexes the arm. Does it flex the arm? It abducts the arm. It laterally rotates the arm. All of the above or none of the above. What is the answer? Action of latissimus dorsi. So is it a muscle of the arm? No. Does it have anything to do with the arm region? Abducts the arm. It laterally rotates the arm. All of the above. Let's see if there are any answers that is given by Mohan Singh Rathod, who says good evening. Hi, good evening. And then we have Rishabh. He says good evening. Hello, Rishabh. And then we have Dr. SK, who says answer is B. It abducts the arm, latissimus dorsi. And then Bharat says it is A. Is it flexion of the arm? So we'll keep all the options open. Let's not keep anything, guessing here. Let's go to the answer and check what is the answer. See, latissimus dorsi is one of the superficial muscle of the back. It is one of the superficial muscles of the back. Somebody says E, none of the above, all of the above. We'll see. So now here it is responsible for extension, adduction, transverse extension, also known as horizontal abduction. So all these are there, and from the extended position, all this can be done. So why? Because it is a muscle which is present on the back side, and it forms a small tendon, and that goes to the arm. If this is the arm, you'll see that there is this tendon going to the intertubercular sulcus. It has a small tendinous insertion. So insertion is very, very small. So it can only be a assistant. So it will only do adduction and extension and internal rotation. Do you remember what is the other name given to this latissimus dorsi? This is also known as swimmer's muscle. Just imagine yourself swimming. What do? You always try to bring your arm closer. So the deltoid will abduct, and who brings it closer? That is the latissimus dorsi. So you need two actions in swimming. One is push your arm away and bring your arm closer to your body. Pushing your arm away is done by deltoid. Bringing it closer is done by latissimus dorsi. That's why we call this as the swimmer's muscle, and the antagonist to this is the deltoid muscle. During this action, you also have to shrug your shoulders. And also you have to steady it. That's why you have this trapezius also working. So now all this is possible when you know what is the action done by latissimus dorsi. So you have to imagine a action with this every muscle. For example, deltoid is abduction. So when do you do abduction? When you want to throw a ball at somebody, you do abduction, right? So swimmer's muscle, how do you interpret this? It's swimmer's muscle, deltoid action, and latissimus dorsi action. Deltoid will do abduction, and once you pull your arm away, you have to bring it closer also. So that action is done by latissimus dorsi. Hence, it is also known as swimmer's muscle. Very important. Okay, so the answer was the none of the above, because here there is nowhere it is given adduction. Adduction is not given. What is given? It is given abduction. So don't get confused. This is by deltoid. Who does flexion? Flexion of the arm is done by the arm. So it is not forearm. So it is done by teres. Then lateral rotation of the arm. Lateral rotators, there are so many lateral rotators. That is SIT muscle. Okay, the subscapularis will do medial rotation. All this will do lateral rotation. All these are supplied by suprascapular nerve, except the teres, which is supplied by axillary. So action of this is very important. That is medial rotation. So I hope I have made this clear. All right. Next one. Triangle of auscultation is associated with all of the following except. Now, triangle of auscultation, you think in that direction. We have YR, we have red tie. He says, how are you? I'm doing good. How are you? You doing good? Good for us. Okay, next, Donna. Donna wanted to reply to some question. I think you can try with the next question. Next question is here. Please try, Donna. Then we have Akshit Bhatta. He says an answer, and then there is again red tie. He was mentioning some answer. Okay, what is the answer for this one? I have not put the question number because question numbers are again confusing. People try to go with the question number, and They will not concentrate on the question. That's why. Triangle of auscultation. So triangle of auscultation, just think, where did you do the auscultation? Is associated with all of the following except it is at the back side, right? It's at the back side. So it is, you can do auscultation where there is no muscle. Otherwise, how can you hear for the sounds, breathing sounds? You can't hear. So there should be no muscle present in that region. So what are the muscles forming the boundary? Boundary is formed by which one? Boundary of the triangle. Just think. So triangle of auscultation is associated with all of the following except. So we have to find the one which does not form part of the boundary. Now you just imagine which are the muscles which are present in this region. Latissimus dorsi was there. What about teres major? We have to find the one which is except. So keep this in mind. Which one does not form the boundary, we have to find. Not the one which forms the boundary. Okay, Mohan, think. Medial border of the scapula is on that side. Trapezius is also on that side. Teres major is also close to that area. Latissimus dorsi also. But where is rhomboidus major, minor? Where are these? Where is rhomboidus major? Okay, let's see. Keep the option open. Okay, answer is B. All right. What is this one? The teres major. Teres major is the answer. The one which does not belong. See, if this is the scapula, this is the medial border. So when we have already picked the medial border, you please remember what are the muscles on this side. L, R, R, L. So rhomboidus is also gone with that, right? L is levator scapulae. This is latissimus dorsi. So latissimus dorsi is also gone with that side. So what we are left with? This is taken, and this is taken. We are left with the trapezius and the teres major to pick. Trapezius also forms the border. The only thing that does not form is teres major because it is present here. This is for triceps. This is for teres major, minor. So it's on the lateral border. And since the triangle of auscultation is on this side, it has got nothing to do with the triangle of auscultation. How many of you said B? How many of you said B? YR said B and SK said B. So it is teres major muscle. All right, now little more information on this. This is the small triangle that you can see. You have the trapezius, you have latissimus dorsi, you also have this medial border of the scapula. So all these things are present. Latissimus dorsi, trapezius, scapula border, and then you also know that the 6th and 7th ribs form the floor. And apex, you see that the lungs are present. Apex of lower lobe of both the lungs you can see. And this is known as triangle of auscultation. So it is the place where there is no muscle. So there is a gap between the muscle. And that is known as triangle of auscultation. Okay, next one. Yes, the answer is B. Okay. All right, Rishabh also says answer is B. We'll move to the next one. The attachment of lateral epicondyle is all. So the attachment of lateral epicondyle is everything except. So you please see this except. Usually when we are in a hurry to answer the question, we forget to see some of the words. We will see what we want to write. So, okay, you have to see what is the actual question, not what you want to just think. So here, attachment of lateral epicondyle is there. I did not stop at that. I went ahead and read the full question. It says except. So you have to think what are the attachments of lateral epicondyle and pick the one that does not belong. That does not belong to the group. So now which one does not belong to the group? Is it, see, lateral epicondyle, what it gives rise to? It gives rise to all the extensors. So all the origin of extensors. So extensors start with E. Extensor carpi, radialis longus. Extensor carpi, radialis brevis. And then there is extensor digitorum. So what is the answer? How many of you think this is the answer? Anyone who thinks this is the answer? So what is left? We are left with pronator teres. We are left with pronator teres. Let's see what are some of the important points about pronator teres. Pronator teres forms part of cubital fossa. So it forms the border. Medially, it's bounded by lateral border of pronator teres. So you must remember the cubital fossa is bounded medially by lateral border of pronator teres. So very, very important. It's a very, very important point to note down. It is not medial border. It is lateral border of pronator teres. That is the boundary of cubital fossa. So that is one important thing. And it also is a muscle for pronation. Pronation of hand. You have pronator teres and pronator quadratus. So two muscles are there for this action, that is pronation. Okay, next one. This indicates the extensors, common extensors origin. Sometimes it can get inflamed. Okay, it can get inflamed, and inflammation is because of constant usage of this region or constant use. What is the condition known as? Anybody has any idea? What is the condition known as? If the extensors are overused, that condition is known as lateral epicondylitis. Lateral epicondylitis, which is also known as tennis elbow, which is also called tennis elbow. Okay, next one. We'll go to the next one. All these you can see the extensors, it is written very clearly. It's a common extensor origin, this point. Okay, tennis elbow, yes. Okay, do you know what is golfer's elbow? What is golfer's elbow? Golfer's elbow is nothing but the common flexor origin. Yes, medial epicondylitis is known as common flexor origin, and this is where the inflammation happens. Next one, the profunda brachiae artery passes through. What is profunda? What do you mean by profunda? Profunda means deep. Okay. So the deep branch of brachiae artery is known as profunda brachiae artery. And this one passes through which space? There is the upper triangular space, quadrangular space, and lower triangular. There are three spaces. There is the upper triangular, quadrangular, and a lower triangular space. And you can keep your fingers like this and you can get the three spaces: upper triangular, quadrangular, and the lower triangular space. Okay, this is the way you have to remember. So now, which one is related to this one, profunda brachii artery? So I'll give you a hint. Along with this, there is a nerve also passing through that. Any nerve idea which nerve? SK says lower triangular space, and most of you says it is lower triangular. Lower triangular is very closely related to the bone, that is humerus. Okay, so on the humerus, what bone? The shaft of the humerus it is related to. So which nerve I'm talking about? I'm slowly coming to the answer. Which nerve? Which nerve? Think, think, think. Radial nerve. Kumaran says radial nerve, and Nirbhay also says radial nerve. Yes, you're right. Is radial nerve. Radial nerve also can get compressed here. It is not just the profunda brachii artery. Radial nerve also sometimes can get compressed in case of aneurysms. Okay, so this one is known as triangular interval syndrome. Triangular interval syndrome. Note it down. I don't think anyone has mentioned this before. It's called triangular interval syndrome. It is for the, this is so there is a triangular space here. This is where the circumflex vessel is there. This is where the other vessel is there. So can you see this one? This is the triangular space, and this is a quadrangular space, and this is also a triangular space which is closely related to the humerus. In this, it is even more clear, and you can see here there is one quadrangular, there is one triangular, and there is another one triangular. This area is related to this shaft, and shaft, which groove is present here? The radial groove. Along with the, because biceps brachii, the profunda brachii, the brachial artery is in the arm. So it cannot be this high. It is again on the shaft. So now here in the shaft, it passes through this, and profunda is always deeper. It is deep. So it also supplies the bone. Okay, it also supplies the humerus bone. So you must remember this can get damaged along with the radial nerve. So along with the radial nerve. And the syndrome where the radial nerve is getting compressed is known as triangular interval syndrome. Okay, please note this. Radial nerve and profunda brachii pass through triangular interval, that is the lower triangular space. Now here you can diagnose the radicular pain in the upper arm, upper extremity. The person or the patient can complain. So such a pain can be due to compression or entrapment of the radial nerve. Okay, entrapment of the radial nerve in the lower triangular space. It's a very, very important thing. And one more request, if you have been liking or if you are finding some questions are new and you are able to answer and you're happy about the way you are answering, please hit a like. Please hit a like, give me a thumbs up so that we can make more such questions to make you think and answer. So thinking and stimulating your brain is very, very important. We can do that with your likes and follows. So if you follow, like, we get more motivation to make more such videos. Okay, so we have about 8 people watching. All right. The next question. the musculocutaneous nerve supplies? It's a very simple question. In that, I will ask you 3 questions. Let's see. SK says yes and yes. Akshit Bhatta says all of them. What is the root value of musculocutaneous, Akshit? Akshit, what is the root value of musculocutaneous? Any idea? It is C5, C6, C7. Right? This is one thing. And if musculocutaneous is absent, which nerve takes over? Any idea? Any idea which nerve takes over if musculocutaneous is absent in the arm? Many a times there is a condition, the musculocutaneous just is, it is not present. In case it is absent, so the entire muscles in the arm will not be, deprived of nerve supply. It will be supplied by something else. The radial nerve cannot supply because it supplies the extensors. So which nerve will supply? You should be thinking of the nerve which has these roots. Which is the nerve that has these roots? It will be, no, radial nerve will not supply. I just told radial nerve is for extensors. It won't crisscross. These are flexors. So which is the nerve that also supplies the, yes, Akshit, it is median. Median has C5, C6, C7, C8 and T1 root value. What about radial? That also has C5 to T1 as the root value. So it has all of them. This has all of them. The first 3 is for the musculocutaneous nerve. So if this is absent, it is taken over by the median nerve. So it will supply both arm plus forearm flexors in that case. So this is one variation that you can identify. Yes. Dr. SK, yes. Akshit, you're right. All right, next one. The answer is A. And one more interesting thing that you can see is it pierces this muscle. It is a coracobrachialis. Pierces the coracobrachialis muscle. Okay, next one. The impression for arch of aorta is on. So where are we? We are talking about arch of aorta. We are thinking about thorax now. We were in upper limb, we suddenly moved to the thorax. So now you start thinking about the questions in thorax now. What impression we are talking about? Impression of arch of aorta. Arch of aorta is on which side? It is leaning to which side? Is it to the right side or to the left side? Arch of aorta, is it below or above? Kumaran, think. Arch of aorta is above or below the lung near the diaphragm? Akshit says above. So what we have to eliminate first is, first you learn to eliminate. So you eliminate first what is not required. Let's eliminate all the right ones, okay? Eliminate the right ones. So first eliminate the right. No. Look for right. No. So we are left with above the hilum, below the hilum. Is it above or below? Only 2 options. It is SK who has written above. We have Merlin who has written above. You're right. Reti above. So the answer is C, which says above the hilum. Can you see this arch of aorta? So this is what is the arch of aorta. You can see there is descending aorta and arch of aorta. So this is the hilum. What does this ligament do? What is the function of this ligament? Anyone has an idea? Kumaran also says above. Pulmonary ligament. Pulmonary ligament is formed by which pleura? How is this pulmonary ligament formed? There is a costodiaphragmatic. Which pleura forms the pulmonary ligament? Yes, parietal pleura. These are all parietal pleura only. But which parietal pleura? It is costodiaphragmatic and costomediastinal. Not this one. Not the cervical will be here. The costodiaphragmatic and costomediastinal together, they fold and they form the pulmonary ligament. So that is again part of the parietal pleura only. This allows the expansion of these vessels. It gives more room for these vessels to expand within the hilum. So they can expand within the hilum. That's why we have this pulmonary ligament. Yes. So you can see this arch, you can see, and of course you can see, why do we think that this is on the left lung? Because you have this structure that is called lingula. You also have cardiac notch and you have an impression for left ventricle. So with all this, we know that it is the left lung. Lingula is a feature of the left lung. It's a small projection. It's a small projection that you can see from the anterior border. This is the anterior border. This is anterior border. This is posterior border. This is diaphragmatic surface or inferior border. Okay, next one. The anterior aortic sinus. Now, where are we? Are we moved to any other section or are we still in thorax? We are still in thorax because we are talking about aortic sinus. Any idea what is this aortic sinus? It is definitely to do something with the heart, right? So there is left coronary artery, right coronary artery as the option. There is interventricular artery and there is all of above. Which one is formed with the anterior? So how many aortic sinuses are there? There is an anterior one and there is a posterior one. So anterior one gives rise to what? Posterior one gives rise to what? Two things we have to think now. So this is the answer. See, you can see there are all these are called the Valsalva. How many of you knew this is called Valsalva? Yes, that is the space that is present in the cusp. So all these are the cusp. There is a cusp here and this is a space and these spaces are known as sinuses. And here you can see that these are called together, they're called Valsalva. All the three are together called sinuses of Valsalva. So it's a very, very important word that you need to remember because sometimes a simple, straightforward question need not be asked. It could be turned and twisted and they could be asking what is the other name for this. And the other name is Valsalva. If you're hearing this for the first time, please go hit a like and follow me so that I can give you more such MCQs and you will be thorough in your NEET PG, right? Okay, so now the right coronary artery arises from anterior coronary sinus. The left one arises from posterior. So we were talking about anterior. So that is right coronary artery. The answer was right. How many of you wrote it as right? Why Dr. SK writes it as left? What made you write it as left? Okay, the sinus of Valsalva also are known as aortic sinuses, as you can see. And these leaflets are present on the interior of the atrium, and on the outside you can see that very close to the root of the aorta these are. On outside you have a bulge. So that indicates that these rootlets are the ones, or these cusps are the ones which are making the outside appearance as bulged. So they are together called Valsalva, and we are answering it as the right coronary artery for the anterior coronary sinus, and the left one arises from the left posterior aortic sinus. So keep this in mind, the answers, because today we are talking about right one. Tomorrow the question, or in the NEET, it could be the left one. It's very important that you know the story in full, not half. So you might be knowing about right. If you don't know about left, then it becomes a half, understanding of the question. Next one. Okay. All are peculiarities of the clavicle, except. Now there are so many peculiarities that you can discuss about the clavicle, right? One is it a horizontal long bone? Yes, it is a long bone. It is horizontally placed. Yes, you're right. A is correct. But the membranous ossifying long bone, it is a membranous ossifying bone. Yes, that is also a correct statement. So we're looking for the proper statements. Next one, Taiba says it is D, and SK says C. It has two primary centers. Is this not a correct one? Why SK is going wrong with many questions? Of late, the 3-4 questions are not answered right. SK, can you answer why you're going wrong? It has two primary centers. That is also correct. It is correct. It's first bone to ossify. It is the first bone to ossify. Now, all peculiarities. Let's see what is the thing. The answer is the peculiarities. Let's see. Now, it is the only long bone which lies horizontally. We had. It has subcutaneous. Yes. It is the first bone to start ossifying. We didn't say that it will finish ossifying. Correct? What was the option there? It is the first bone to ossify. Did they say start? Where is the word start? Where is this word start? Yes, Retta, you have to come for this 9:30 class. 9:30 class that has all clinical based, all clinical questions. So attend 9:30 class on YT. Okay, this is for red tie. Okay, so you attend 9:30 question. Let's see how much questions you can answer, how many questions you can answer, how much you can grasp. But before that, to answer any clinical based, more clinical will be there. But you are also going to have all these theory based questions. It's not only clinical based, it is also theory based as well. Okay, next one. What is the answer? Last bone to ossify. But where is this word? Start. So it's starting at first one to start the ossification, but it is the last one to complete at about 25 years of age. Okay, at about 25 years of age. So it will take so much time to ossify. So it is the only long bone which ossifies by two primary centers. Someone said there is no two primary center. So SK can look at this statement. Two primary centers are present. Next, it's the only long bone which ossifies in membrane. So it is the membranous ossification. What is membranous ossification? Red tie. What is membranous ossification? What is one clinical condition? What is one clinical condition associated with the membranous ossifying bones? What is a clinical condition? Anybody has any idea? What is a clinical condition with membranous ossifying bones? Now, those are the clavicle, cranial bones, and we have one more, that is mandible. Okay, what is the clinical condition? I'm expecting an answer from red tie. What is it? Anybody? Yes, it is called dystosis. It is not dysplasia, it is dystosis. Dystosis. Pedocranial dystosis. You're right. This is the answer. So SK says it is cleidocranial dystosis. So you have to have some information about the theory part before you jump into the clinical aspect. Otherwise, you will not know how to relate. That's what I'm trying to tell you. You will not know how to relate, and then you will your information is incomplete. When you have a information that is not 100%, then it becomes very difficult to understand the clinical condition. So theory is very important. Theory part is very important. So once you master the theory part, you will be very good with the clinical applications. Okay, next one we have here membranous ossification, and then it may be pierced by cutaneous nerve, that is supraclavicular nerve. So this is one important aspect. So here this will be related to fractures of the clavicle. Now this is the only long bone which ossifies in membrane is related to this condition. Two primary centers. So this is again with the ossification. Now this one is again to do with the ossification. Now subcutaneous throughout. This is again to fractures. You can talk. No medullary cavity. Okay, it has only compact bone outside. There is no medullary cavity. This is the bone which lies horizontally. And all these are some of the peculiar features of clavicle. Next one, the cells in the morula lies within. Now we are talking about which one? Are we talking about thorax? Are we talking about something else? What are we talking about? Is it not? It's not thorax. We jump to something else. What is this morula about? We're talking about some embryology topic. Embryology. Okay. So you have the cell pronuclei, then you have two cell stage, there is cleavage formation, and it goes on multiplying to 8 cell stage, then 16, then it goes to 32, then it goes to 64, and so on. And that is when you get your blastocyst. Right? That is the blastocyst. Now, here you have zona pellucida, zona interna, externa, none of the above. So now cells in the morula lies within which one? So now here you must remember the morula is properly covered by a thick outer covering that is called zona pellucida, because it is not yet reached the 64 cell stage. This is the time, it is about 5 to 6 days. This is the time when it goes for implantation. Okay. So what is the endometrium where it gets implanted known as? It is known as decidua. Decidua basalis. Next one. See, this is the word And you know that it is contained within the zona pellucida. You can see two cell stage, and then that turns into many cell stages. Ultimately, it reaches morula, which is 16 cell stage, and then it will become 32. That is also called morula. Then you have this blastocyst. It has the cavity, blastocyst, and it has this inner cell mass, which is known as embryoblast, and outer cell mass, which are known as trophoblast. What are these cells called? These cells are called blastomeres. They're called blastomeres. And then you have this next one. There is this epiblast and hypoblast cells that are formed. You have this trophoblast cells, and trophoblast cells will go on to form the placenta. And the embryoblast are the ones which divide into two things. So this will divide into epiblast and hypoblast. Epi and hypo. And that is what this is. Epiblastic cells and hypoblast cells. Now you can see that the region above this is amniotic cavity. The region below this is primary yolk sac. That will convert into secondary yolk sac later on. So this is the morula 16 cell stage, and it gives rise to blastula, blastocyst. The precursor cells are the zygote. Okay, next one. How many of you know this answer? The chondrocytes in elastic cartilage. What are we talking about? Are we talking about embryology now? No, we have moved to histology. The chondrocytes in the elastic cartilage are the ones which form the part of cartilage. Now there is elastic cartilage, hyaline cartilage, and white fibro cartilage. Now out of these three, the chondrocytes in case of elastic cartilage, what is the arrangement? What is the arrangement of cells? Is it in vertical row? That is seen in whom? That is seen in the white fibrocartilage. Cell nest is seen in hyaline cartilage. And horizontal row, vertical row, groups. Which one? Which one do you think? So you can see that the horizontal row, you can see, not the vertical. The horizontal row is seen in white fibrocartilage. The groups are seen in elastic cartilage. Let's see the answer. This is elastic cartilage. You can see it is similar to the hyaline cartilage. Everything is similar except for the cells, which are called chondrocytes, which are bigger in nature, which are bigger, and they are scattered, and they could be arranged in groups like this. And location is epiglottis and ear pinna. You remember E for all this elastic. Elastic, you remember epiglottis and ear. So now it maintains the shape of the structure while allowing some flexibility. You can see a lot of elastic fibers in the matrix. So matrix has a lot of elastic fibers. That's why it is called elastic cartilage. And this is actually a magnification of 640. Otherwise, usually the cells are observed with the 10x. So they don't look this big, and so much of clarity is not seen in the cells. And here all these elastic fibers you can see. Okay, they look more pink because of the staining properties. Okay, next one. The serous demilunes are extensively seen in. This probably could be the last question. The serous demilunes. Now you have another histology question. So where do you think is serous demilunes? So there is sublingual gland, parotid, submandibular, and serous salivary glands. So sublingual is nothing but it is a mucous salivary gland. What about parotid? That is also serous. This is also serous. Submandibular is mixed. The serous is the serous acini, mucus has mucus acini, and the serous submandibular has mixed. So mixed with a serous acini and a mucus acini and a demilune. This is how the mucus acini looks with the flat nuclei. You'll see a flat nuclei. So it is, no, serous demilunes are the features of submandibular, which is a mixed salivary gland. Okay. So you will see in the parotid, you will see only serous, pure serous. In the sublingual, you will see purely mucus. And in submandibular, you will see mixed, which has got this demilunes, and that is called mucus. And on top of that, you will have a cap of serous. This is serous. And this cap is known as demilune. So it is known as serous demilune. So that's what is the answer. Let's go to the explanation on the same. There is three types of acini. Serous you have, mucus you have, and then you have mixed, which is also called mucoserous. Okay, it's also called mucoserous. Here you have mucus. That's why, see, mucus will not take up stain. So that's why it looks more light in color, because the secretion is something that does not take up staining. And then you have serous, which looks pink. This is pink, and this is the cap, and this is also known as crescent of Guernsey. Crescent of Guernsey is the word that you have to remember for mixed salivary gland. Mixed salivary gland example is submandibular salivary gland. Okay. So that is one important question. Next one. Example of cruciate muscle is, now there are so many muscles and there are so many classifications. There is unipinnate, bipinnate, there is recti muscle, and there are fusiform muscles. All these muscles are present. There are some muscles which crisscross, the fibers crisscross, and these muscles are called cruciate. What is the example? Anyone? Fearless, any idea which one? Is it deltoid? Deltoid has a particular shape. And Anconius is in the elbow. Pronator quadratus, it is in the forearm, wrist area. What about deltoid? It is in the shoulder. So here the answer is pectoralis major. Pectoralis major is an example for cruciate muscle. So such questions are asked. It's not all the time it is clinical. Clinical is important, but such questions are also asked. So don't miss out on the questions. Now here pectoralis major is a cruciate muscle. The fibers originating from the upper half of the muscle cross over the other set of muscles that is coming from the lower half. The upper half of the muscle, they'll do the action to bring the lower fibers downwards, and the lower fibers, they do these actions. There is flexion and adduction. So adduction is a very important feature of pectoralis major and teres major. So both the majors do adduction. So is latissimus dorsi. So this is lady between the two majors. So all of them do one action, that is adduction. Who is the antagonist to this? Antagonist to this is deltoid. Antagonist to this is deltoid muscle. So they have an anatomical twist in the muscle, and that's why it is called cruciate muscle. It's an example for cruciate muscle. With this, I'm going to stop at the MCQs for today. Thanks for watching. Please don't forget to subscribe and like the videos that we post. Your likes are so important to us, and then we get motivated to do better with your likes and comments. And then please subscribe for the plus classes, which is even more interactive and interesting. And I have every day at 6 p.m. your YouTube classes, and I have at 10:30 p.m. you have the special classes, and then you have another one YouTube at 9:30. So please watch all the three. The first two are MCQ based. This is the general and this is the clinical. And the 10:31 special class is the topic based discussion. So with all this information, look forward to, yes, are you coming at 9:30? Yes, red tie, I'm coming at 9:30 with clinical based questions. That's exactly what you wanted. So we have clinical based questions at 9:30. See you then.